We have all experienced it in one way or another. Some live with it daily, while others really suffer from it. But in one way or another, before we pass from this life, we all have our own amount of pain. Dr. Robert Hauptman is the Medical Director of Medication Management at Health Point Pain Center, Vice President of Medical Staff at the Sturgeon General Hospital, Treasurer and founding member of the Alberta Pain Society, Chairperson for the Salvis Family Medical Clinic, member of College of Physicians and Surgeons of Alberta Chronic Pain Guidelines Committee, and the Assistant Clinical Professor in the University of Alberta Department of Family Medicine.
So chronic pain is a major health problem in Canada. In fact, globally, we understand that 1 in 4 to 1 in 5 people suffer from chronic pain. What basic science has taught us in the last 10 to 15 years is that chronic pain is itself a disease that is clearly different from acute pain and even cancer pain. We do understand that 100% of all pain virtually comes from the brain. When I look at a patient with chronic pain, I try to apply 6 basic fundamental ways of looking at how to manage their pain, what I call the 6 pillars of pain management. The first one is lifestyle, looking at things within that patient's life that we can adjust. This is things around nutrition, sleep, and exercise. For example, one thing we know for people with chronic pain is they tend to be more inactive than people without chronic pain, and a lot of this is because of the pain itself. There is a fear that if they move, that they get more pain. Often they do. The interesting thing is if we can get our patients with pain moving, they can sometimes get significant reductions in their pain because exercise, particularly low-impact cardiovascular exercise, releases chemicals that help to heal the brain. So again, lifestyle is very important. So that's the first pillar of pain management. The second one is optimizing medications. So that we have a variety of pharmaceutical medications that we can use for our patients to try and relieve some of their pain such that we improve their function, which is again still a very important goal for us in the pain world, functional improvement.
For some people, the most commonly used drugs are either ineffective or cause serious interactions, some that can even lead to death. In many cases, this is discovered too late.
I have been practicing medicine now for 30 years, so I've watched this develop over the last 20 years. One of the problems with the concerns over opioid usage in North America and Europe has been this rise in prescribing with a consequence rise in opioid-related accidental death. In fact, at one point, the CDC called it an epidemic. I think part of the problem with this was this idea that acute pain and chronic pain must be the same disease. So if opioids work really well for acute pain, they obviously should work for chronic pain. And so in the 80s and 90s and moving into the 2000s, there was this sense that if a patient has chronic pain, we should use opioids, and we should use enough opioids to relieve their pain. This led to large amount of opioids being dispensed in North America and Europe.
The global pharmaceuticals market is worth $300 billion US a year, a figure expected to rise to $400 billion within 3 years. The 10 largest companies control over 1/3 of this market, several with sales of more than $10 billion US a year and profit margins of about 30%. 6 are based in the United States and 4 in Europe.
As mentioned earlier, so chronic pain is basically a neurological phenomenon where a brain goes from being healthy to unhealthy, and that although opioids may have a part in the management of some people with chronic pain, clearly it doesn't work with everyone. In fact, nothing works with everyone. I think the other problem, and you know, I think we have to be honest here, is I'm not entirely sure it was as much an opioid crisis as much as a crisis of irresponsible or uneducated prescribing. Again, a lot of primary care physicians and consultants trying to help people with chronic pain, but really not knowing how to do so responsibly, how to screen for addiction, for example, how to limit dispensing of medications so that we weren't prescribing large amounts to a potentially susceptible population. Understanding what is the true risk of addiction with opioids. There is a risk, but it's not 100%, nor is it 0%. So I think what we've now come to understand in the last 5 to 10 years is how can we do this more responsibly? How can we do better pain assessments? How can we screen better for addiction? And how can we look at our patient populations and say, this person would benefit from drug A, this person is going to benefit from drug B, and this person is going to benefit from drug C.
It is predicted that North and South America, Europe, and Japan will continue to account for a full 85% of the global pharmaceuticals market, well into the 21st century. Companies currently spend 1/3 of all sales revenue on marketing, roughly twice what they spend on research and development. It should be noted that anytime we introduce an artificial substance into our bodies, whether it be a pill, alcohol, or processed foods, smoking, etc., it's likely going to cause problems, since it is far from what our bodies should ingest. There have been natural herbs and plants that humans have learned to use to combat disease and pain throughout recorded history.
The brain is a very complex organ, and the nervous system is as well. We know that there are opioid receptors scattered throughout the body, just like we know that there are cannabinoid receptors scattered through the body. The cannabinoid receptors are where marijuana works.
And a growing number of the public are discovering the benefits of cannabis and other natural remedies.
The use of medical or herbal marijuana is a very timely subject in Canada. Over the last 5 years, this has become an evolving intervention or therapeutic intervention in people with chronic pain when traditional therapies have failed.
Dr. Mark Ware is the Associate Professor in Family Medicine and Anesthesia at McGill University, Director of Clinical Research at McGill University Health Centre, Co-Director of the Quebec Pain Research Network, and is the Executive Director of the nonprofit Canadian Consortium for the Investigation of Cannabinoids.
We've conducted a number of studies looking mostly at either synthetic or smoked cannabis for the treatment of fibromyalgia pains and for the treatment of neuropathic pain caused by nerve injury.
We know that about 70% of the activity of opioids is actually on the peripheral nervous system and only about 30% on the brain when it comes to relieving pain. In terms of cannabinoids, I'm not sure that we've kind of sorted that out as much.
In a nutshell, what we found is that cannabinoid drugs based on cannabis, appear to have some analgesic properties. They're not powerful analgesics, but they're modest, and they're generally well tolerated by patients. So they have a reasonably good side effect profile.
I found that there is clearly a percentage of individuals that have really responded nicely to medical marijuana when other more traditional therapeutic options have failed.
We're still talking about the interaction of chemicals in the cannabis plant with the human body with the view to improving pain.
When I do prescribe medical marijuana to this population, I do make them quite aware of both the risks and benefits as I would with any therapeutic agent.
But why is there so much misinformation, fear, procrastination, and such dogmatic opposition relating to even the medical and legal use of such a natural and effective remedy?
When it comes to herbal cannabis, it's a little bit trickier because there's no company per se that's declared an ownership or that has an intellectual property position where it can study cannabis and then sell and maintain an ownership of the claim. So there hasn't been much investment from the private sector.
From my perspective, the individuals in my practice who I've prescribed it, most of them have done quite well, and it's improved their pain and function. Occasionally, like most meds, I have found people that just can't tolerate it. Currently, I would estimate that anywhere from 5 to 10% of my chronic pain population is using medical marijuana that I've approved. Again, this is opposed to street marijuana.
We haven't formally studied the proportion of responders in a real-world context. We've looked at this in clinical trials, and I think approximately a third of the patients who we have administered cannabinoids in clinical trials, and these are small studies, but about a third seem to demonstrate some kind of response.
For those people that have responded to medical marijuana, I'm pleased to say that that's what we've seen. An improvement in function, a reduction of pain, and doing so with minimal side effects.
I think that there's a suggestion that remains to be shown conclusively that the combination of chemicals in cannabis act together to potentially cause a better response than any one of the individual compounds by themselves, whether they be synthetic or otherwise. I think that's something which is supported in part by the fact that patients prefer using herbal extracts to the single agent compounds, which we have had on the market for some time now. But that said, we have patients who respond very well to the single agent synthetic cannabinoids, and they do very well on those too. So I think there's probably room in the toolbox for all of these players.
If you look at the end point of death as a side effect, particularly unintentional death, that cannabinoids seem to be safer than opioids. It's a lot easier to get an accidental death on opioids, particularly when they're combined with other central nervous system depressants. I am unaware of any deaths that have been directly associated with marijuana usage, although there are certainly indirect deaths that I'm familiar with in terms of motor vehicle accidents. There's definitely been cases of people impaired on marijuana that have resulted in accidents. Yet directly, marijuana causing a overdose-related death, I'm personally unaware of that being ever documented.
I by no means think that this is a drug that will help everybody that has pain, but it appears that there's a subset of the population that may.
So there are definitely differences in terms of opioids and cannabinoids and how they are reacting in the body. What's really interesting, at least from an animal model point of view, there's some good evidence for synergy between these two groups of drugs, that using cannabinoids with people on opioids can sometimes increase the efficacy or the treatment effect of both of these compounds. So this is an evolving science. I know that Health Canada has approved some of the licensed producers in Canada of medical cannabis to do some prospective studies on the use of medical or herbal marijuana in chronic pain conditions. In fact, one is currently ongoing with the use of medical marijuana in osteoarthritis. So there's still going to be more to come as we better understand how to use these medications in individuals with chronic pain conditions.
One of the challenges ahead of us now is to figure out what it is about certain patients that causes them to respond positively, and also what it is that makes them respond negatively. Some people have very bad experiences with cannabis, makes them very anxious, paranoid, or even psychotic.
The 6 pillars of pain management are crucial in trying to help with all aspects of pain. What you have experienced here is a small peek into the first 2 pillars, that being lifestyle and medication.
I think what we really need in Canada is better accessibility to active rehabilitation programs for people with chronic pain. We know many of these individuals have had pain for 5, 10, 15 years, and getting them involved in an active rehabilitation program is essential in helping them to restore their function.
What is it that we can study to help examine and identify the responders and make sure that we're minimizing the harms to patients by picking really the right patients for the right drug?
Your educated choice is necessary when choosing medications, from morphine to marijuana.
I've learned a lot from the scientific community, I've learned a lot from my colleagues, and quite frankly, I've learned a lot from my patients.
It is necessary for you to continue the journey with me in the search for the pain truth.